Hello, everyone. My name is Lisa Forbes-Satter, and it is my distinct honor and pleasure to welcome you to the inaugural JMF Speaker Series presentation. Good morning, good afternoon, and good evening. We are 501 registrants strong from 65 countries. What a wonderful opportunity to share in Vicki and Fred's vision. This speaker series is meant to be a global initiative designed to inspire connection, accelerate innovation, and transform how primary immune deficiency is understood, diagnosed, and treated. These engaging virtual events will bring together and educate physicians, researchers, nurses, and other healthcare professionals by sharing cutting-edge developments in PI, groundbreaking research, clinical insights, and fostering cross-specialty collaboration and more. It provides an accessible and ongoing forum to feature the work in our field. And it speaks really well to what Vicki and Fred wanted to engender into our field in 1987 when they started the Jeffrey Modell Foundation in honor of their son, Jeffrey, who passed away at age 15 from complications related to primary immune deficiency. Their story is one of turning personal tragedy into hope for families worldwide, and their unwavering commitment has led to policy changes, scientific discoveries, and community building across countries, which all of you have been an integral part of. Jeffrey was bright, funny, deeply loved, and though his life was short, his legacy lives on through every patient helped and every diagnosis made. And this speaker series honors that legacy by continuing to pursue knowledge and connection that Jeffrey himself inspired. And what a more fitting day to start this speaker series than on Vicki's birthday. We honor her lifelong dedication to turning loss into hope and celebrate not only her vision and compassion, but the countless lives she's touched through her unwavering commitment to patients, families, and global PI community. Education was at the forefront of everything that she did. And so even more fitting is that every November 10th, we celebrate World Science Day for Peace and Development, which highlights the important role of science in society and the need to engage the wider public in emerging scientific issues. Education is celebrated today not only through Vicki's birthday, this JMF speaker series, but around the world to commemorate World Science Day. Education was one of her deepest values, and it's our goal to ensure that our community has free access to high-quality lectures and information, and in a reflection of her enduring belief in the power of knowledge. Connecting the community to educate, advocate, and innovate, she always believed we were better together. In this inaugural event, we will feature insightful discussions from the present and future of PI, from leading experts Jordan Orange and Isabelle Meyts. Together, their perspectives will provide attendings with a comprehensive understanding in our field, as well as new developments in treatment methodologies and research updates. Due to the ongoing US government shutdown, Dr. Luigi Notarangelo, better known to all of us as Gigi, is regrettably unable to deliver his portion of the speaker series presentation, The Past of PI, as originally planned. We're deeply grateful to Gigi for his time, partnership, and continued commitment to the Jeffrey Modell Foundation's mission. His insight and presence will be greatly missed during this inaugural event. However, we look forward to welcoming him to the future and to speak on the past of PI in a future JMF series program once the circumstances allow. A few housekeeping items. During the program, we will feature the speakers. And then when both are finished with their wonderful presentations, at the end, we will entertain questions. Please put them in the chat or the Q&A feature so that when we are done, we can get to your very valuable questions. So it is my distinct honor and pleasure to introduce to you Dr. Jordan Orange, whose research career has been pivotal in advancing the understanding of intracellular immune reactions, immunologic synapse work, and causes of immune deficiency through mechanistic insights for inborn errors of immunity. He's played a key role in major discoveries in our field, and his team gains deep insights into the roles of natural killer cells and increased focus upon those that apply therapeutically. He was the director of the JMF Center at CHOP that was dedicated in 2004 and presented with an endowed chair from the Jeffrey Modell Foundation there in 2010. He was professor and vice chair of research and chief of immunology, allergy, and rheumatology at Baylor College of Medicine and the director of the Center for Human Immunobiology at Texas Children's Hospital, where there is a recognized Jeffrey Modell Foundation Diagnostic and Research Center inaugurated in 2013. He was the Reuben S. Carpentier Professor and Chair of the Department of Pediatrics at Columbia University and Physician-in-Chief at New York Presbyterian Morgan Stanley Children's Hospital. And recently, he rejoined the Children's Hospital of Philadelphia in September of this year as Pediatrician-in-Chief and Chair of the Department of Pediatrics and at the Perelman School of Medicine at the University of Pennsylvania. Dr. Orange has many accolades and awards, including the National Academy of Medicine, and he is a merit awardee of the National Institute of Allergy and Infectious Diseases. Most importantly, he has been a mentor, sponsor, and dear friend to many of us on this webinar and to the Jeffrey Modell Foundation. It is my distinct pleasure to have him here. Congratulations, Jordan.
Thank you, Lisa. It's a privilege to be at this inaugural session of our global community. Also, regrettably, we do not have Gigi with us today, really we had divided some thoughts around past, present, and future. So we'll start with the present. I know that everybody will look forward to hearing from Gigi soon, as soon as he is able, and so that he can really take a step back and recap some grounding as to how we are, where we are, why we are. But I will jump in with a few words about the past, but moving to the present. Of course, it's always inspiring to hear from Fred, and we'll look forward to that at the end of the webinar. So, of course, Vicki and Fred inspire us with all they've done, with all they do. And today, of course, being Vicki's birthday. Of course, the movie story of Jeffrey, if you have not seen, you should, available at no cost. Of course, we're all part of this very large network, which has grown substantively via Vicki and Fred and the foundation to really provide some wind into the sail of what our field is, and the very large centers network, which now constitutes over 930 physicians, 415 institutions across 90 plus countries, and its progress captured periodically. It's an inspiring community, and I know so many of us are proud to be a part of it and look forward to its future. Its present, of course, however, is what brings us together today. As we heard a bit, the foundation is committed to innovation in our field and to supporting those world over and advancing it. The foundation has awarded almost $7 million in research across 3 different categories of programs, which you can learn more about on the website, and I encourage everyone to do so. I know many of you have received these, and some have aspirations to do so, and your ideas from world over can attach to impact. Of course, Vicki, who we honor today on her birthday, was a tireless advocate for research. And here you can see her in front of houses of government, really making the case for research into our field of primary immune deficiency. And this dated back now 35 years ago, shown here in this announcement from the federal funding agency in the US, really recognizing the work of the Jeffrey Modell Foundation and codifying that in a funding announcement to try and draw funds for gene transfer for primary immune deficiency from 1995, and leading to other codified examples of funding directed from the US government for immune deficiency, which many have benefited from, all recognizing the Jeffrey Modell Foundation, and you can see the JMF and Vicki's efforts inherent in those funding announcements. And this and so many other things have led to the growth of our field to where we are today. This from the most recent IUIS classification, just showing the massive increase in the number of our diagnoses. 559 inborn errors of immunity classified with the graph from the paper in the New Journal of Human Immunity, showing the increase across categories in red for the number of diagnoses that now become part of our field and our repertoire. And how inspiring is that? And it's really research that makes this possible. It's outstanding individuals across our field taking care of patients, bringing innovation to patients, all of you and all of your efforts that really make this possible. But our patients are on an odyssey, and how do we help bring that to end? It's certainly something you're all passionate about, that we are all working day in, day out to try and advance. And I want to highlight one reference that came out in the Journal of Clinical Immunology recently, which shows that patients who are in the midst of a diagnostic odyssey, that there is a benefit to them in terms of their own reported health of having that diagnostic odyssey end. If you look at the value between undiagnosed and diagnosed, it's statistically different. And the longer the diagnostic odyssey, the greater the negative impact on reported health is. So we really have to end the odyssey. And this is a performance art piece by an artist that was a few years ago. He was trying to find a needle in a haystack, and he spent an entire day looking for that needle. And this is really what many of us do. And how do we bring this odyssey to a close for the benefit of our patients? And how do we use the tools available to us? And these tools are growing. We're growing tools in the way of phenotype-based diagnosis, of improved genomic approaches, and of augmented intelligence-assisted recognition, as we like to call AI 2PI, with the goal really of getting undiagnosed patients to zero. And so just to share a few thoughts in the way of a few-minute introduction of the topic, phenotype, we're able to look closer than we ever have, and tools for phenotype. And I want to highlight this really critical reference from a few years ago, which is the Human Phenotype Ontology Project. And this group of authors listed here, including many of you, came together to really bring better phenotypic terms into these databases so that we could actually use these tools to find our patients. And the outcome of this was simply phenomenal. Looking at before all of your efforts to reannotate these phenotypes and after, showing that a clinical vignette, the likelihood of that attaching to the actual and accurate diagnosis changed so drastically because of the better phenotypic tags associated with this database available to us. And this is really just a wonderful advance, a wonderful use of technology and the tools we presently have to end the odyssey. We also have wonderful tools like this, like Gestalt Matcher, which is able to look at some of the facies associated with genetic phenotypes and be able to really try and match those to best available alignment to individual diagnoses. And there are many others, but these are just examples of how we can even use the phone that we carry around with us to be able to advance diagnosis. Of course, this has been, as we see the massive growth of the IUS categories, really reliant upon genes, tools, and new insights from genes. And this has been just a tremendous era of exponential growth of the explanations of the phenotypes that arrive in our clinics that have been under our care. And here from a few years ago, a summary looking at the output of diagnostic approaches from genetics, whether these are next-gen panels, exome sequencing, plus copy number variation. The results were roughly the same across studies in that about a quarter of individuals to whom an approach was applied, that there was a diagnostic outcome. And this could be looked at in a variety of ways. For one, what's being missed. For two, that when we as a community and as experts have a pretest probability that we think that there is a genetic primary immune deficiency, that there likely is one, at least 1 out of 4 times. And that is really useful in being able to end a diagnostic odyssey. It's interesting to think about what's in the other portion of this, the 3/4 of unsolved, and that we'll get to in a second. But what about this 1/4? What about when we have a pretest probability? And that led to I'd say, the really innovative program of the Jeffrey Modell Foundation, Jeffrey's Insights, which was initially piloted, but the idea was not to have any barriers, but when one of us had a suspicion of a patient having a genetic immune deficiency, just make a test available. Don't ask any other questions. Don't require any other sort of barriers to be crossed. Just make the test available. And here was the first phase of that had just a small number of centers and a few patients in it, 158. But what that found was that, again, about the same, that there was about 1/4 of individuals who ended up with a genetic diagnosis. And in the last iteration, with almost 1,400 patients, the results were the same. And the project and the initiative continues, and the data accumulate. And now there's over 4,000 patients in this program, and those data will be reflected back to everyone soon. But again, the outcomes being the same. And if you look across regions, again, diagnostic rates of about 25%. And what's really heartwarming is that the change in management and treatment from the ability to have sent a genetic test is over 1/3 here shown in the bottom. So really just having access to the tools makes a difference. And the same outcome in this paper, I love on so many levels, shows the same outcome in a resource-constrained setting. And here, using targeted genomic diagnostics, over 1/4 having a diagnosis, and the management changed in over half of those who had a diagnostic test. Also want to share some work that was presented at the most recent ESID meeting, in that actually using genetic testing when you do have a pre-existing suspicion can result in a significant cost savings compared to traditional testing approaches. Now, this is granted using US data and US costs, but this is a variety of modeling approaches looking at the conservation of dollars by just starting with a next-gen sequencing approach when you have a high pretest probability of there being a genetic immune deficiency. And it shows the value of everybody's assembled expertise. But genetics keeps going. And here, this paper from Dusan Bogdanovic from just a few months ago shows this, and Isabelle really wanted me to put this in here to bridge to her future comments, but that this paper really shows the concept of monoallelic exclusion, and that how having a single variant in a gene can result in a full-blown immune deficiency phenotype. And the genetics of this are really fascinating. And I encourage everyone to take a look at this, but I think this is a paradigm that helps us reduce the unsolved portion, the 3/4 of our undiagnosed patients, and will result in a paradigm I think that many of us will be navigating with our patients. But it grows further still, and I want to point out this wonderful review article from also just a few months ago, which was focused to CVID, but really applies, I think, to all of our diseases, in that we think, of course, about monogenic, but really need to be thinking much broader still. Somatic variants with skewed X chromosome inactivation, multifactorial features, epigenetic features, polygenic, oligogenic, and digenic, and the tools to really make these diagnoses, including polygenic scores and certainly expression analyses, epigenetic analyses, are really coming our way. And really to have this broader concept as we think about what happens to the 3/4 of patients who remain in the currently unsolved, undiagnosed category. And so how do we find our patients and end the odyssey? And I think there's some important things to keep in mind. One, that the systems we have in place do introduce some biases. And here's a paper that came out looking at some of the disparities in genetic testing. This looked at two programs that had, one was a sponsored program, one was an unsponsored control. And they both ended up with populations that were different from the general population, really suggesting that some of the systems in place led to missing some patients, although there could be other explanations. And then a paper that we just published recently in the JACI in Practice really showed the same, is that if we looked across, and this was sort of a scoping evaluation, if we looked across all recent published cohort studies, and we looked at ones in the US only compared to the US census data, that there was a significant difference in all of these major diagnostic categories as to what was diagnosed and present in the cohort versus what would be expected for the general population. So we need to keep these in mind, I believe, as we really try to reduce any considered bias, and as we try to find all patients. And I think here AI presents tremendous hope. And so here's some of the work of Nick Ryder, and he was using the Jeffrey Modell Foundation's Spirit Analyzer to identify high-risk individuals, and then applied AI-based neural networking to really try and probe further and find more patients, and to find the terms that, in an ideal sense, remove any bias from identifying patients at risk. He took this a step further and did what I think might be the first natural language processing approach, and really looked at all clinical notes and tried to pull all kinds of variables out of them to improve further the ability to find patients. I also want to highlight the recent work and publication of Manish Butte, who did a wonderful similar series of works in the University of California health system to really find and identify and train to be able to pull out of these systems people who are at risk for common variable immune deficiency. And what he found is, if he would have run back to patients who had the diagnosis, would have found many of them years before their actual diagnosis. So really, how do we do this further still in a way to remove biases? Well, of course, newborn screening, and it's been a sort of long platform of Jeffrey Modell Foundation. And here was the original US series looking at TREC screening and some of the outcome, with at least over 3 million screens there, finding 52 SCID cases and finding a number of other things. And this is now globally in place, and certainly every state in the US. And this wonderful nomenclature and series of recommendations for how to go about newborn screening for SCID, and I recommend this to everyone strongly. And where do we take this next? And is it a time to really get to screening for all? And just want to share with everyone this recent example of genome screening offered to all babies born, and this was in in a New York region, but I know many such examples in place. And the first question was, would people do it? And the answer there was arguably very much yes. And so there was a lot of concern, would people who just had a baby agree to whole genome sequencing? Here were the reasons that people didn't want to do it. And the most common reason was that they just weren't interested, or I'm overwhelmed by having a new baby, much less so that there was a distrust for research or genetic research. But compared to the standard screens offered in the state of New York, there were only 6 positive screens from the state of New York, and whole genome sequencing offered to every baby born identified another 110 diagnoses. And that was inspiring. But what were the chances that there was actually a hidden in their case of IL-2RG atypical SCID who had a normal TREC assay? And that was absolutely sort of bewildering, because that's supposed to be a very rare event. And what happened here, and again, this is the data of Josh Milner and Ramsey Fullahan, is that there were low T cells, low naive T cells, and there was absent STAT5 stimulation, as would be predicted by the this was a known IL-2RG variant that was found in some other individuals. And here was this otherwise healthy baby who now was identified by whole genome sequencing. And so after much discussion and presentation broadly, he was transplanted successfully from his identical sister. And here she is, here he is, and he engrafted well and has been doing really well. And here's just a video clip to hear from her opinion.
Saved him. I felt like a superhero. I'm so happy that he's alive. I'm happy that he's in my life.
And so, again, I'd say a wonderful output of whole genome sequencing at birth. And but that work continues. And believe it or not, there was another TREC negative, a normal TREC screen identification here of an ADA variant. And on both alleles, and this individual had absent ADA levels and is presently being treated. This kind of experience has been reproduced here, also published in Nature Medicine, another population-wide screening. And I would say that we're on the precipice of really being able to do things we never have, and I know we all look forward to that. And then, of course, intervention. And I'd say now more than ever, and we'll hear more from Isabelle in just a second, but there's precision medicine and interventions for our patients that we could have never dreamed of. And here, the upcoming practice parameter from the Quad AI, CIS, and college under the Joint Task Force. And Dr. Forbes-Satter led a part of that, and a group that pulled together precision interventions. These are ones approved by the US FDA, and there's also a whole series of them that are presently off-label, of course, that we all rely on and use. But what a wonderful moment that we have an armamentarium of interventions and therapies that can be applied to our patients based upon their specific diagnosis. So, I would conclude by saying that we really build upon a storied past and a vibrant present to create an inspiring future, and certainly look forward to that. And so grateful to be with all of you today and to be with all of you in that journey. And with that, I will stop and pass over to Dr. Isabelle Meyts and back to Dr. Forbes-Satter.
Thank you, Jordan. That was amazing. We are so grateful for the time that you spent to put that tour de force together as to what is going on currently. And now we have the distinct pleasure of hearing from Professor Isabelle Meyts, who founded the Division of Primary Immune Deficiency at the Department of Pediatrics, the University of Leuven, in 2007, and was recognized as a Vicki Modell Foundation Diagnostics and Research Center in 2011. Her research activities are centered around translational research in PID and focuses on genetic and functional characteristics of known and novel PID, on disorders such as adenosine deaminase type 2, and her research, for which she's received an ERC starting grant, Professor Meyts continues to innovate in expanding phenotypes and the way that we think about our IEIs. She's a winner of several awards, including the Edelweiss Award from the Rare Diseases Organization in Belgium. She's also a former president of the Belgian PID Group, the European Society of Immunodeficiency, and she's currently the president-elect of the Henry Kunkel Society. Very much huge accolades in primary immune deficiency and immune dysregulation. She's a senior clinical researcher at the FWO Vlaardingen and the UZ Leuven PID unit. Patients can count on advanced diagnostics and treatment, including hematopoietic stem cell transplantation, through her leadership and her work. And she is also a dear friend, a mentor, sponsor, and very much adored by many of us on this webinar. So it's such a great pleasure to introduce her, and I look forward to your talk, Isabelle.
Thank you very much, Lisa, and thank you very much to the Jeffrey Modell Foundation for inviting me for this inaugural series. So I want to discuss with you the positive and bright future of what is possible for primary immunodeficiencies. So slides are not moving, but maybe they are now. So for me, I think building on what Dr. Jordan Orange just said, we need to continue improving our diagnosis of primary immunodeficiency. And when we can do that as a network, we can really join forces and move forward in this direction to be able to shorten the diagnostic odyssey as he exemplified. Also, I am very much convinced that together we will be able to improve the treatment and the outcome of our patients, and by doing so have more attention for their quality of life as well, which is all the more important if we manage to diagnose and treat a patient. So in my opinion, what are let's say, our hidden potential in terms of improving diagnosis? I think I want to build this in 4 directions with you. And one of those first steps is to basically looking at the natural course of disease. As we all know, in the most unideal situation, we are waiting for symptoms to occur before we can reach a diagnosis. We know that Vicki and Fred have basically advocated throughout their entire lives for prenatal diagnosis, for track diagnosis, and to be able to diagnose upfront a condition as severe as severe combined immunodeficiency, but all the other primary immunodeficiencies as well. So basically, we don't want to wait for symptoms to occur, and we want to be so much earlier in the trajectory of a condition to be able to prevent severe disease and irreversible organ damage. And I think that is basically what we need to be able to do in the future. It's to prevent the suffering of these patients with primary immunodeficiency. And so it's very clear that for almost all of the conditions we are seeing in the clinic, that the outcome will be better if we diagnose earlier. And so one of the building blocks here, in my opinion, is that we continue to increase and enhance awareness. It was one of the, let's say, the primary bricks that Vicki and Fred have always, let's say, been found so very important. It's to talk about primary immunodeficiency, to use the warning signs in college, in all medical disciplines, but also in society. So when you walk into the airport and you see the warning signs, you're going to read it. You will be attentive to it. If we don't talk about it, people will not know. Even in the future, this talking, this awareness in whatever way will continue to be important. So I really want to highlight that even with AI, even with all the data we have, there will still need to be awareness for conditions. Artificial intelligence, and I think if you look at the PubMed search that I just did just last week, the results by year are speaking. So artificial intelligence combined with, let's say, human intelligence is going to be the future of diagnosis of PI, but we need to tackle this in a smart way. And again, here, the Jeffrey Modell Foundation really put the standards high by already starting to look into AI in primary immunodeficiencies and how we can improve diagnosis. I think it's clear that we are collectively generating so much data. It's incredible. We are doing genomics, we are doing transcriptomics, serum samples, blood samples, examining the patient, doing CT scans, and so on. And all of these data need to be able to come together in, let's say, a highly qualitative way and in a uniform way, so that it becomes also accessible for machine learning, and so that we can, again, in a global view, join all these data and learn from these data to help enhance diagnosis. And basically, we need to be able to do that, let's say, in a global way, because only in that way we will be able to diagnose the N=1 or N=2 patients with rare primary immunodeficiencies. And I also want to highlight a more easy way of looking at this. I put there the calculated globulin, just calculating the total protein minus the albumin. It's so useful, and then there's been several publications to just highlight detection of primary antibody deficiency. So even artificial intelligence can in a way be quite simple, and if we start to use it now and move forward in that direction, I'm sure we are going to be overwhelmed with the capacity and the potential of this future. Neonatal screening, another headlight, always deemed very important by Vicki and Fred, and also basically one of the challenges that they put for all the JMF centers in Europe is to really get neonatal screening over here in Europe and basically everywhere. Neonatal screening for SCID is not yet universal in Europe. As you can see, I'm from Belgium, we are not doing it yet, so we ought to start in 2026. So the future for us is hopefully already going to be better, but there's a lot of disparity. And I think, again, looking forward, we need to be able to get rid of that disparity and to be able to screen at least for severe combined immunodeficiency. And if we join forces, we will be able to do that. Looking further, and again, building on what Jordan said, it's not only about SCID. We need to screen for so many more diseases. And here I put the cracks as one of the potential tools for the future, one of the many. But I think SCID is very important to screen for, but also other conditions that maybe at first sight look sort of less severe. For instance, XLA. But it's a very severe condition. If you look here at this paper by Banchilitu in the Journal of Clinical Immunology a while ago, several of these patients with XLA had quite severe lung disease with bronchiectasis and any kind of lung disease. So it's not an ideal condition to have. And again, if we find it more early in life, maybe we are able to do something better than the mere immunoglobulin substitution, and we can sort of prevent disease. And this is not a mistake of my slide. This is IK virus. Viral infections in these patients can really cause disseminated disease, complications that urge the condition to become a transplantable condition. So it's not a simple antibody deficiency. And to build on this further, I put here two papers that stress the mortality risk or the cumulative mortality in patients with primary immunodeficiency. So the left-hand side, you see a slide from this recent update of the European Society for Immunodeficiencies registry in the Journal of Human Immunity. And I just built some marks. These are the IUIS classifications, but you can see here. So basically the first category is the combined immunodeficiency, and you see that there is substantial mortality here in the first few months of life, but then basically thanks to our transplant and thanks to what we are doing on that side, we have a better survival. Whereas, for instance, intrinsic and innate immune deficiency, they are here. And for instance, combined immunodeficiency, there's substantial mortality in the early, let's say, years of life of these patients. And we should do something about that as well and keep that in mind. And this is another paper that from recently published, also looking at, it's a meta-analysis and looking at the mortality reported throughout the IUIS classification. And you can see that, for instance, lymphohistiocytosis, but also CGD has substantial mortality. And I think in that way, it makes sense. And I'm reporting here what Jordan highlighted in his talk. I think the way to go is to go for genomic screening at birth and to combine this with a very good clinical network. And basically, if we look at the potential of AI and of gathering data and keeping data and reanalyzing data at some point, we should be able to diagnose a severe immunodeficiency at birth. And I don't want to come back to this, but I think it's really important. This is what we would rely on to screen for SCIDs, but it was picked up, this baby, thanks to the genetics. And I think that's really important. So you know this panel, the number of conditions is growing, and I think it will continue to grow if we all join forces and continue unraveling novel PIDs and novel inborn errors of immunity, I'm sure the list is going to be much longer. I recently had a discussion about this with a few colleagues, and so there was a bit of dooming, thinking that we would not be able to find more inborn errors of immunity or primary immunodeficiency. I'm basically, for the future, I'm convinced of the opposite. And to build this conviction a little bit into the future, I was looking into a paper from 2005, which I found very interesting. We can think, for instance, of the genes that we believe to be associated with immune function, as for instance, genes that are already connected to the genes that we have unraveled to be a cause of immunodeficiency. But we can also look at it from another perspective. And this is a paper by Abul Abbas, who basically looked at the transcriptomics of several subsets of immune cells, either stimulated or not, and he found that there was an immune response transcriptome that reflected about 1,600 genes. So we are still far off. If we want to only look at, let's say, the low-hanging fruit, then of course maybe we are done. But I think the future is going to have to go to those high-hanging fruits, and I think with all the tools that we have at hand, that's going to be possible. Again, if we join forces and if we work together and let's say don't hide our ventures and keep open science in mind for the benefit of the patients. So my goal for the future would be, or my message or hope would be, to combine the power of next generation genetics, be it transcriptomics, genomic sequencing, and so on, with that of the futuristic molecular immunology we have at hand. Because looking at this paper from the ISIT registry again, we see that there's still a substantial group of patients without genetic diagnosis. This can be because there is no access, for instance, to genetic diagnosis, but it can also be because we were not able to convincingly validate one or another variant of uncertain significance that came out of any or another panel. So we have to be able to combine the power of NextGen with all the tools we have at hand. And this is just an overview of all that we can do. It's just amazing these days. You can think about it, develop it as long as we have the money to do all of this, it should be possible to go all the way. And I like this particular paper by the group in Columbia University, where they did a scalable variant classification of PIK3, CD, and PIK3R1 variants by adenosine base editing at a massive scale. And they went on to look at the cellular profile of these edited cells, and they used phospho-ACT as a readout. And in this way, they classified all the variants as a gain of function or a loss of function on the other hand. And they were able to translate this in several population databases and reclassify variants that had been, for instance, called variants of uncertain significance into pathogenic variants, and in this way opened the way for therapeutic intervention for these patients. So I think this kind of scalable variant classification is going to be the future for many of the conditions that are at least, let's say, suitable for this approach. And then also Jordan already touched on the incomplete penetrance. There's the monoallelic expression, but definitely probably we need to look further and need to dig into, for instance, predicting based on a polygenic risk score, like beautifully presented by a group in Harvard for telomere disorders, and in this way predict whether a patient will or will not have cytopenia when he or she inherits this variant. We need to think about epigenetic influences, and at this point this is still very difficult to study in the field of primary immunodeficiency, but it's definitely something that we have to dig in further. And then there's the entire field of non-coding RNAs that will probably make up our individualized risk profile for the patient. And in this way, it can help us to reclassify variants of uncertain significance. So I think that's really important. We have to realize that genetics, yes, very important, but we need to be able to validate the variants. And that's why we need global collaboration. And maybe we each have to have a few favorite genes and work for the entire world to make this happen. And I want to cite this sentence because I thought it was so good, because basically in the near future, we may have access to comprehensive catalogs of gene-specific variants, building on current approaches in which variant effects are evaluated across diverse genetic backgrounds, cell types, and tissues, and also look at the multiple gene-specific outputs. And this will help us to use a predictive pipeline where we can estimate the probability of pathogenicity. And if we do this in an organized way, in a global way, I think we can come very far. And then I was thinking, one of the, of course, challenges is we need a lot of money to do all of this, right? And despite all the efforts throughout the world to fund research in primary immunodeficiency, it is still very difficult to get money because we are often regarded as looking after rare. And that's important because these are rare diseases, but sometimes it's good to float on what I would say the common. And in this perspective, I found a New England paper that recently came out quite interesting, because this group found, just by exploring databases, population databases, they found several rare diseases variants, known pathogenic variants in patients with what I would call common diseases, like, for instance, atopic dermatitis, MS, and also IBD. And several of these patients, for instance, had Shwachman-Diamond syndrome. So we need to think maybe also towards less phenotypical and more molecular diagnosis for these patients, and in that way serve a little bit on the flow they have going for their not so rare diseases. Think about lupus as an example. A few years ago, let's say 10 to 15 years ago, a common disease, not so many monogenic conditions there, but look at how the field has evolved now. And I think that is maybe something that we can explore further in the future, which can be a momentum for the study of primary immunodeficiencies. Being better at diagnosis is only important if we are also better at treating. And here I would build on the fact that if we are able to stratify the risk for a certain patient to develop disease when he or she carries a certain variant, we can perform informed stem cell transplant from a diagnostic point of view, but basically, in my opinion, also from a important or let's say a donor informed point of view. It's good to know the donor. We all carry rare variants that may be disease making, yes or no, and maybe the disease hasn't expressed yet. So I think also in the field of stem cell transplant, we are going to evolve to more certainty about what we are doing. Patient-specific gene therapy is already there. We just need to be able to implement it even at a higher scale. And I think that's going to be the future if we're able to control off targets, and if, again, we have enough funding available for this kind of development. Drug repurposing, I'm a big believer in that perspective. I think many drugs originally developed for treating other conditions are going to be important for the field of primary immunodeficiencies, and we have to be able to test those. And I'm highlighting this let's say, where they treated embryos that are actually modeled for 22q11 deletion. They treated these embryos with minoxidil or prostaglandin E2, and what they found is that, in fact, they were able to switch down the SOX9 positive cells and were able to restore the structure of the thymuses in these mouse models. So the future is also into looking broader into mechanisms and using molecules that we have available, maybe for another therapy. I want to highlight also the magnificent field of CAR T-cell therapy. Imagine treating a patient with lupus a single time with CAR T-cells and being able to switch off disease for a long term. That's amazing, and that's something that we'll probably be able to do for many more conditions in the future. And maybe not by lengthy in vitro procedures, but maybe by in vivo procedures, giving RNA that are enveloped in lipid nanoparticles to the patient, and in that way restore a disease. And in this way, we will have time and energy to focus not on surviving, but on really on the quality of life of the patients. We also need to continue, and we will continue working on better basic treatments, better antivirals, more antivirals, antifungals, antimicrobials. We need all of those. And I just want to highlight this paper. It was always my dream to be able to see the development of immunoglobulins, not by mere plasma donations, but also by in vitro modifications that would enable us to save immunoglobulins for, let's say, for the life-saving properties they have in terms of infection prevention. And here, the anti-inflammatory activity that we usually only see with 0.8 or 1 gram per kilogram IVIG infusion is elegantly recovered by FC fraction engineered sialylated IgG1. And that is actually so tightly bound to the FC gamma receptor 2B that it switches off the autoimmune process and that it downregulates the inflammatory activity of the myeloid cell. So the future is really there. This is, let's say, an antibody that is produced in in vitro chain that will able to modify disease. And I come to the end of my lecture. We need to have this, not only in the future to have this, but to have this for anyone affected by PI anywhere and anytime. And what is needed here? It's one world, one community, one mission to treat primary immunodeficiency around the world. And we need everyone, society, patients, researchers, academia, companies. We need all of you together. And I want to stop by this. The future is bright, because look at this Nobel Prize for medicine this year. It was, I think, fantastic and a beautiful synthesis of how basic discoveries, fundamental science, as Lisa alluded to today, it's science party today. Not to forget that it takes a bunch of brains working on this together. I thought that it was a really nice quote to be able to solve something as radical. And then I found this New York Times article. And I want to say, I think in name of our community, an immense thank you, Vicki and Fred. I think you changed the world for primary immunodeficiency patients, definitely. And you also, I think you saw your role as pioneers in this field, and you took it up with an amazing force and an amazing power. So thank you. And thank you all. I want to thank all patients and their parents and families, all colleagues, because it's always wonderful to be together. Colleagues who empower and mentor the future leaders of our field, and all of the funders. And you see the future is bright, because we have every year more junior researchers and medical doctors interested in primary immunodeficiencies. Thank you.
I just want to thank you, Isabelle, for just that wonderful presentation. I want to thank, you said it best, we're better together, just like Vicki always thought. So having both of you here for the inaugural speaker series was such a treat, and absolutely knocked it out of the park. I want to say that we did come up with a way to show you the video. So if you'll give us a moment, we'd like you to see the words from Fred.
Hello, everyone. My name is Fred Modell, and I'm so happy to be here with all of you for the first event in our new JMF speaker series. Now, you know, Vicki believed that investing in physician education was the best way to get answers about Jeffrey. And she had the idea to connect families with physicians and researchers together throughout our global network, and I think it was a great idea. So we decided to launch on Vicki's birthday to honor her legacy and continue the work she was so passionate about in educating others about primary immunodeficiency. Education has always been at the heart of the Jeffrey Modell Foundation. This JMF speaker series brings together the leading experts, industry partners, families, and patients to share cutting-edge developments in primary immunodeficiency, and we hope you leave today feeling inspired about the future. Vicki always said we should aim higher, keep going, and I know she would be so proud of us, all of us here today, talking about the past, the present, and the future of primary immunodeficiency. Thank you for joining us, and I'm delighted to be with all of you.
Couldn't have said it better myself. He's truly an inspiration still, and we're so grateful for his investment. Congratulations to Vanessa, the CEO of the Vicki Modell Foundation, Jessica Quinn, the scientific director, Rachel and Roger, and all of the staff members who really did a great and amazing job in putting this together. We could not have done it without you, and we're so grateful for your support and ongoing support of our community. We have about 3 minutes, so I'm going to just ask a question of the two of you. If we were to reconvene here in 10 years, what do you hope will have changed the most in the landscape of primary immune deficiency? And I'll let each one of you give your vision.
Yeah, I mean, I hope we see larger genomic screening of populations. I think there's a lot of disease to be prevented, a lot of treatment to be able to be made available, a lot of lives to be saved. I also hope that we see true augmented intelligence approaches to assist us in being sure that we're putting the pieces together, that we're not missing things, and that those are just inherently part of our phones, our electronic records, and tools available to us, effortlessly.
Yes, I agree. I hope to see this evolution. I also hope to see that we will be able to classify variants more easily. I think that's also it's crucial. It's good to have variants coming out of sequencing efforts, but so far, the focus was on pathogenic variants. I think if we want to take it a step further, which we need to do, then we also have to come up with a scalable way to classify variants.
I was muted. The future is bright. It clearly shows we have more work to do. And given the attendance on this webinar and all of the wonderful comments in the chat, it shows that we have a cohesive, very invested community to accomplish these goals that we hope to attain. We are approaching the hour, and I think that I wish I had a more impactful words in the English language to say thank you to the two of you for just giving awe-inspiring presentations and for kicking off this speaker series with the most inventive and innovative ways to move forward. So congratulations to all of you for building such a wonderful community, and thank you for joining us, and we hope to see you on the next one. Take care, everybody.